EKG 컨퍼런스 시작하겠습니다. 발표를 맡은 강사 2년차 정재원입니다. 오늘 준비한 EKG는 바이러스 와이드 QRS 타키카디하고 레이트는 120회, 라이트 엑시스 겸 보이고 있습니다. QRS 듀레이션 200ms 정도.
예, 그, 이 원에서 L, 내가 기존에 BBB, 이제, 임페리얼, 풀포달리에 대해서, 그러니까, QAV와 QRS가 이렇게, AV가 소시에이션 되거나, QAV가 정확하지는 않은데, 이 원에서 QRS, X 쪽에 나와 있는 안에 노침을 QAV로 쓰고 있다면, 이제 프로그레이트 QRS가 생각보다 되게 와이드 고 이렇게 한 정도
있습니다.
있을 것 같아요. 네. 저는 일단 VT의 가능성에 준해서 접근을 할 것
이니셜 BP는 이게 그냥 외래 진료 보기 전에 찍은 거여서
같아요. 괜찮은지 안 괜찮은지 모르는 거.
예, 요 이후 요러고 바로 직후에는 다시 네로 QRS 사이너스 리듬으로 바뀌어서 요 당시의 혈압은 정확히 기록. 네.
그러면 뭐 줌으로 참석하신 분들 중에 다른 의견 갖고 계신 분 있으면은 얘기해 주십시오. 일단 조승원 선생님은 VT일 것 같다고 얘기하죠.
아, 네. 저기, 저는 리드 2 보면 여덟 번째 비트하고 뒤에서 여섯 번째 비트 보면 QRS 앞에 피로 의심되는 것들이 있는데 결국은 리프로듀스블하게 보이지는 않고 있어서 VAD 디소시에이션 의심할 수 있는 VT 소견이지 않을까 이렇게 생각이 됩니다.
VT 한번 해볼 주시면 폭발적으로
아, 예. 네, 리드 2 쭉 가시다 보면 여덟 번째 비트 앞에 저 앞에 살짝 조그만 노치 아니 그 앞에 아이솔렉트리컬 라인 쪽에 보시면 아니요.
아,
이고 예, 거기서 쭉 그렇죠. 그 조그만 거 뒤에 보면 그렇죠. 이런 것들이 또 다른 데선 보이지는 않거든요. 혹시나 저는 거기 의심이 됩니다.
진짜 PVF 맞나요?
How about V5, V6 precordial lead? What do you see right after the QRS? V5, V6, V6 lead. 내려가세요. Yes, that notching. Every single one has it. Right? You still think that's a dissociation? Although you can see in B5 as well, that sharp potential right up to the QRS. Yeah, next one. Yes. Yeah, there's all of them has it. Which is deforming your ST segment to downward. So what's the criteria of a VT? And typically when you say V1, you have a R wave duration greater than 40 milliseconds, this patient, right? You agree? Lap bundle pattern. That's greater than 40 milliseconds. Initial R wave. Okay, only the first R. Come back. Yeah, that one to the up. Yeah. That looks like a more than 40 milliseconds in my eye. So that would be favorable for the VT lap bundle pattern, right? What else is favorable? How about AVR? Can you see AVR such QS pattern wide? Yeah. AVR, yes, QS. It just comes straight down, right? Q and S. Anything else? Is the VT notching help? V6 is notching and the R help you? Or is it against that? And the R wave. V6 got the R, yes, come back up, and then they're notching in the top, right? So how many of you we think is a VT? Let's vote. You guys already voted? Sorry, I joined you a little late.
VT에 합당하다고 생각하시는 분들. 참석자들은 대부분 VT.
저도 VT라고 생각해요.
네. 현장 참석자들은 모두 다 VT에 합당하다고 생각합니다.
Okay. Then let's go to next. Everybody agree?
이 줌에서는 VT 할수 있어요.
제가
So if this was VT, you would have a VT with a 1-to-1 VA conduction, right? That's what you're talking?
제가 그렇게 빠르지 않아서 VA 컨덕션이 있을 수 있을 것 같아요.
Okay.
네. 71세 환자분이고
Okay. 그 클리니컬 데이터가 71세 환자고. Anything else?
뒤에
That's it?
뒤에 준비했는데
Okay, hang on a second here, okay? Leave here the EKG before you go there. Second EKG, let's take a look.
네.
The narrow
이게
yes.
방금 첫 아리드미아 EKG 이후에 1분 뒤에 외래에서 시행한 EKG입니다. PVC에
Okay.
동반돼 있어요.
All right. So PVC morphology is same as VT. That's what you're showing, right?
네.
And what else do you see in this ECG? What's underlying rhythm? You got to tell all that because you just said can show EKG. Patient at AFib or asystole or asystole? What do you think? What's going on? Do you see P wave anywhere?
없어. atrial fibrillation이라고 생각합니다.
Oh, really? So have you measured the PP interval? I mean, RR interval of this patient? That one, and then the very last one. 그거하고 전과하고. Is the same or slightly different? Looks different, right?
네.
Okay. So it's irregular tachycardia. P wave is very almost non-visible. And then you have a frequent couplet and isolated PVC. So most likely atrial fibrillation. Okay. Now, what do you see on the V2, that end of a T wave? May I ask you that question? Yes, go to V2. 오른쪽 좀 보세요. T wave에. 야, 그 T wave 너칭 같은 거 있지? 그 다음 거 보시고. 거기 또 있고, 그 다음 또 있어. So that raises what question? Could it be very slow few flutter with a varying degree of block going on, right? Because you can see such a distinctive flutter appearing morphology. But obviously, coarse AFib can present like that as well. So we cannot rule that out possibility here. Okay? All right, let's go. Anything else you want to tell me about the EKG besides the goal? Patient has a baseline right bundle branch block, incomplete. Am I right?
네.
As you can see, incomplete right bundle branch block. How about this patient's precordial lead transition? Is that normal? When you read this 12-lead ECG, what would you read here? Because you got very deep S wave and V6 still, narrow QRS complex, right?
네.
This favor for what? Right ventricular overload, right?
네.
So you have a now clinical scenario a little bit better now. So you have a right bundle branch block, incomplete. Right word axis is very much strong. And then you have a still residual deep S wave in precordial, lateral precordial. And then you have a few flutter pattern. So that's what patient has a private right ventricular hypertrophic pattern or overload pattern. Okay. Anything else you want to add? Anybody else, please? Because your comment is important here. Everybody speak out what you're thinking. So that way we can discuss, make sure we learn, make a progress here. Any other suggestion, the DCG? Okay, then I guess everybody agree. Let's go to next EKG. Okay,
환자 이전에 22년도에 폴터에서 다큐멘트 된
okay. What do you see here? So the patient have still looks like a fibrillation on the line.
네.
And then you have this sequence of PVC, pulse tracing, yes. QRS complex, AV nodal conduction QRS complex, and then you got PVC, and then you have a pulse, okay?
네.
And then you got shorter, fast conducting interval RR, and then trigger this tachycardia, purely monomorphic, and then pretty fairly regular. So what's the mechanism of this tachycardia? Do we know? Can we tell or no? Based on this short, sequence. It's favor for reentry, right? Certainly cannot rule out the trigger activity, but having sequence of a short, long, especially sinus PVC paused by 2 couple of sinus shorter interval in initial tachycardia, that probably predisposed to develop reentry mechanism. So if a patient have a heart failure, severe, and then patient keep presenting with the atrial fibrillation underlying rhythm, and then keep coming with the recurrent ventricular tachycardia, sometimes just by regularizing the AV nodal response to the ventricle regular way, then patients start having VT. So that's why somebody has already by ICD, heart failure with the atrial fibrillation, having recurrent VT. First thing you need to think about whether is a mechanism of reentry. If that's the case, simple procedure, just the AV junction ablation. Let the patient be paced all the time, regular basis. That alone sometimes, reduce the burden quite a bit. So that way it's a quick procedure. You can save a patient a lot of discomfort. Okay?
네.
All right. Anything else want to add? Anybody else, please? 전부 다 조용하네, 오늘은. Okay. 갑시다, next. Okay.
그래서 이게 당시의 베이스라인 ECG입니다.
Okay. Yes, so we still don't see P wave anywhere almost, this patient. Yeah, maybe chronic AFib. But you know, RR intervals are fairly slow. So you start wondering whether patient already have probably avian conduction disease or 600 syndrome complex. Okay. Now, did you measure this PP interval cup between the two PVC? First, narrow QRS, the next one, and then third, fourth. Did you measure it? Are they same or they're different?
달라 보입니다.
틀려? Okay. Because if it's the same, then you need to start raising question, is this patient truly in the maybe AV block with the underlying AFib? Then your management would be quite different, right? Because you already start thinking about putting defibrillator to this patient because patient already have a complete heart block with a regular RR interval that would be junction escape rhythm underlying AFib. Then your clinical management would be completely different. Okay?
네.
Okay, go ahead. The next slide now. Let's see. Okay.
언더라인
Yeah. Go ahead.
DCM 히스토리 있고 AFib 있던 환자분입니다. 그리고
Okay.
류마틱 마이트럴 리거지테이션으로 MV 리페어 2000년도에 시행받으신 분이고, 그래서 앞서 보여드린 홀터에서 보였던 아리드미아에 대해서 VT 어블레이션 시행했던 분이고, 또 언더라인 헤모다이알리시스 하시고 있는 분입니다. 이번에 외래 인터미턴 체스트 페인이 있어서 내원을 했는데 찍은 EKG에서 다음과 같은 소견이 있었던 분입니다. EPS 스터디 2022년에 시행했을 때는 RVOT 데로셉텀이랑 LCC 쪽에 어블레이션 시행했었습니다.
지금 이번에 프레젠트한 EKG 보시면은 프리비스 여기하고 좀 틀린 게 B1에 지금 R웨이가 많이 커져 있죠? 그죠? 그치? 지금 이건 BT고 그 전에 있던 BT는 B1이 QS였잖아. Almost. Little bit 꺾은 다. Maybe did I misread? Yeah. 이거 봐. B1이 QS였잖아. So what might happening here? You did ablation in RVR flow track and left coronary cuspid에서 ablation 하셨는데 지금은 B1의 RV가 그러했다면은 this tachycardia exit site is more toward the left, right? So you may be heading to the left septal anterior junction or aortomitral contiguity area, almost like a summit pattern. So this VT that he presented, the new VT, I don't know whether new VT or same VT, but clearly acts are quite different. So it looks like a new VT. So you trying to study this patient again, ablate, or what are you doing? Planning to do with this guy? Okay, so you did the coronary angio.
예, 우선 코로너리 워크업 했고, 서컴 OM 바이포케이션 쪽에 모더리티 칼시피케이션 동반돼 있고, LAD도 모더리티 스테노시스 있어서 FFR 시행했고 0.8 이상으로 코로너 인터벤션은 시행하지 않았습니다.
Right.
이게 이번 외래 내원 전에 시행한 베이스라인 ECG고, 카디악 MR까지 현재 시행했고, 레이트 가돌리늄 이네스먼트 패턴은 포컬하게 있지는 않다고 판독 받았습니다.
Okay. So what's the plan? What would you recommend to this patient? Patient need ICD.
ICD는 필요할 것 같습니다.
Right. And then would you consider to have a ICD or just the ICD? Because right now your atrial fibrillation is fairly well controlled. And this ECG looks like a fairly stable RR interval. But then patient when have a tachycardia patterns, I don't know how they initiated VT, but certainly had a short sequence. And what's the EF for this patient right now?
이젝션 프랙션은 34% 정도로
Percent. Okay.
글로벌 하이포카이네이지와 동반된
Right.
모델 리드스 테
So one possibility that you may consider putting out 5-EICD and then just ablate AV node to make a regularized QRS complex. That's one possibility. Other option, put a dual chamber pacer or single chamber ICD, whichever you want, and then you do BT ablation. What are chances about us doing good BT ablation in this patient? Pretty good or pretty moderate success or low success? What you say? You have a diffuse dilated cardiomyopathy patient, and then patient and renal failure patient with a low ejection fraction. And then there's no distinctive substrate in MRI, looks like what they say. So currently taking amiodarone already, 50 milligram. Is that for VT or for AFib?
for AFib.
AFib. So did you increase the cortisone already or no? It just still kept at 50 milligram?
일단 유지 중인 걸로.
Right. But you have to remember that amiodarone really does not affect too much in renal failure patients in it per se, but then they do have some slow metabolism, so they even get longer metabolization. So that's something that you need to think about it. So patients certainly taking very small propranolol, so you could increase a little bit more if you could push that for heart failure treatment as well. And renal failure patient completely dialysis dependent, you said, right? You don't need to worry about the renal toxicity or anything like that. He's already done deal, so you may have to add some more vasodilator a little bit, perhaps. So somebody going to study this patient soon or no?
교수님, 내용 교수님 환자분이신데, 5N CRT 하시고, RF는 좀 고려 중이신 것 같고요.
Right. Good. Okay. That's good.
프로파놀은 좀 늘려서 지금 쓰고 있는 상태입니다.
Great. Okay. That's good. That's the right thing then. Okay. Got the answer. Okay.
네, 이상입니다.
Thank you.
교수님, 저 질문.
Yes. Yes, please.
처음에 그 VT 때 아까 V5, 6 뒤에 나칭이 이제 결국 저게 PWAV인지 아닌지 저희가 항상 원래 이전에 PBC에서는 또 보이지 않았던
Right.
저런 패턴이 왜 생기는지 혹시 제가 궁금해가지고 어떤 걸로 해석을 해야 될지.
So, two issues there. One is that if you look at the V2, there's a small notching in the front as well. Do you see it?
예.
Right. You see that? My interpretation to this is that the patient probably has a very slow conducting epicardial focus coming out, close the septum. So when you have that, also you can have a very small, activity coming on. You can detect that in surface ECG. So this focus is a little bit more, if you will, perpendicular to, a little more opposite side of a V2 area, probably. And the septal area may be coming out and then conducted through the anterolateral wall because of previous ablation of RV outflow tract and then the area. And that V6 is also means very slow conduction zone area. Yeah. So because of that terminal now, V6 is, remember, you're looking more to the negative portion of the S of the RV. So this patient have a conduction delay right ventricle, very slow. Okay. So this patient has a right ventricular conduction delay up to, as well as the right. And then that is a reason that you cannot do, when you see such a small fragment signal average ECG, because they're falsely positive. That's a contraindication, actually, when we see this pattern. That's why the right bundle branch block, we don't do signal average ECG because the reliability drops quite a bit. In patient have a left bundle branch block pattern, has a terminal noisy, you will have always a positive signal after ECG, meaning is unknown. Okay? That's what
네.
that. Yeah.
네, 감사합니다.
Okay, good case. Thanks for teaching. Let's go to the case. Oh, you're going to give a lecture today?
네,
Oh, great. Okay, that's great. 오늘 원재 선생이 이제 팀 리더야?
리더는 아니고, 네.
That's a good thing. Sometimes senior guys take a break here and there.
이거를 나갔다가 다시 해야 돼. 나갔다가 다시 바로 시작해야 돼.